service come up with recommendations without either an oncologist or urologist on the panel. So I just have a problem with basically all their recommendations. So but I included it more out of humor than anything else. But the Europeans are actually more assertive about using and incorporating imaging into the risk assessment. I'm going to just say a few words about coronary CT. This involves use of contrast. Now you can identify with a high degree of sensitivity and specificity the presence of not just non-calcified plaque, but not just calcified plaque, but non-calcified plaque. And this tells you what the impact is. Interesting. You mentioned about the this is the patient with no CAD. This is the patient that has non-obstructive CAD, meaning they don't have really tight disease, but they have plaque. And this is the patient with obstructive coronary artery disease. What's interesting, the only patient that was really free of events in high degree were the patients who had no CAD. So here the presence of any plaque, besides that were non-hemodynamically significant and hemodynamic significant plaque, these patients had very similar outcomes. And we always say that the diabetic patient is so different than non-diabetic. It really seems to be that the non-diabetic and the diabetic population really share pretty similar prevalences of coronary vascular disease. So although I think diabetes is a risk amplifier, I think that we should not minimize our ability to assess those non-diabetic, but certainly I think it is a risk amplifier. So we talk about heart failure. So boy, we're going to cover some interesting topics. Diabetes and heart failure. It doesn't matter whether you have heart failure with reduced ejection fraction or preserved ejection fraction. The diabetics just do worse. Okay, and perhaps we'll hear more from Dr. Geft in terms of that. But there's something about the diabetic heart we call the diabetic cardiomyopathy. And it may be related to how it actually creates fuel for the heart. And perhaps the heart doesn't run, is running on low octane fuel, the heart of the diabetic, and that may be related to the fact that it may use more free fatty acids in glucose utilization. So it's interesting how the diabetic is much more likely to have a worse prognosis with heart failure, and they have a higher prevalence of heart failure. So with all these drugs, this is looking at the FAHA trial. So we're going to move away from imaging and we're going to kind of get into diabetes. So what we found, this is comparing diabetics at baseline versus no diabetics. This is the FAHA trial, which was the cardiovascular outcome trial with evolocumab from Amgen. And what they looked at, it's a relatively short trial, about 36 months, but they found you're able to reduce the incidence of cardiovascular events by about 25% in the diabetic population. But let's look at the absolute risk. You're still having, within 3 years, these patients having a 13% incidence of events. And remember, these patients are basically walking around with LDLs in the 30s, 20s, 30s, maybe low 40s by virtue of the clinical trial. So we talk about this residual risk issue. So, it's clear that even with the use of these hyperstatins to reduce, which I actually think are very important medication, we still have significant residual risk. This is a really interesting slide. So, Carol, you were still in practice during 4S, right? And I was in practice. And the HOPE trial, right, in 2000. So these were pivotal trials, right? The 4S trial was the secondary prevention with simvastatin. HOPE was with ramipril, using ACE inhibitors. So look at the difference in events between the